So kia ora tātou, I'm Charlotte Chambers, sometimes called Charlie, and I'm the new Principal Analyst for the ASMS. I've been there since June. So it was a real privilege to be able to start doing this research, which we conducted back in September. And in my presentation today, I just want to give you a little taster of the research. For the full detail, for the full buffet, if you like, you can read the report which is in your packs. So today I'm going to start by defining what presenteeism is. I'm going to discuss why it matters. I'm sure most of you now have a reasonable insight as to why it does, thanks to the improvisers. And I'm going to touch on some of our key findings. And I just want to start the discussion as to what can be done. How can we start by addressing this issue? Before I start, though, there's some acknowledgements that need to be made. I want to start by thanking over the 50% of the ASMS members who actually took the time in their busy schedules to click on the survey link and share their stories. And with that in mind, can you please also click on the link for our current survey on hours of burnout, because that would be really good too. I'd like to acknowledge Chris Frampton from the Otago School of Medicine. He did all the statistics for me. It's not my strongest point. And also one of our executive members, Clinical Professor Murray Barclay. Murray gave me a lot of guidance in terms of scoping out what types of questions we wanted to ask, and also the members of the executive who helped me with the pilot. I'd also like to acknowledge Lauren Keegan, who assisted with the mechanics of sending out this survey, and the other ASMS staff who gave me feedback and edited the weighty tome. Before I go into the detail, I want to start by sharing some of the stories. One respondent wrote in, "I had very bad pneumonia last winter, but I managed to do a full outpatient clinic while being seen myself in the ED. Another stated, "There is no slack in the system to allow for sick leave. The general feeling is that you should be an inpatient." And finally, this was in the context of describing an extremely short cover situation. "I would find myself locking the office door and hiding under the desk in the dark." Now, these are incredibly powerful statements. Also, pretty grim reading. And I think, to me at least, they convey the immense amount of pressure that you people are all faced with to continue to work through illness, because that's what presenteeism is. So this cartoon says, "That's what I like about Peterson. He doesn't let a little illness keep him off the job." And perhaps that's what your management are also thinking. So presenteeism, broadly defined, is turning up to work when you're unwell enough to be on sick leave. And in the context of this study, we had a reasonably specific definition. We defined it as turning up to work when too unwell, fatigued, or stressed to be productive. We included fatigue or stress in the definition, partly because of the significance of this for your workforce, but also because there's increasing attention to links between working through illness and psychological issues like depression, and also burnout. So there is considerable evidence to suggest that doctors take extremely low amounts of sick leave, especially compared to other professional groups. But as McKevitt wrote in a seminal paper in 1997, this should not be assumed to indicate a lower incidence or an absence of ill health. Indeed, evidence suggests that those who continue to work through illness are twice as likely to suffer coronary events to those who do take sick leave. Bergstrom and Bowden in a 2009 paper made this link between general ill health and rates of presenteeism. And in a more recent paper in 2014, there was a strong relationship found between chances of burnout and working through illness. As I'm sure you all know, presenteeism in healthcare settings can have serious consequences. And in a recent editorial in the American Journal of Pediatrics, Stark and Jackson spoke of the cognitive dissonance between presenteeism and the Hippocratic Oath, primum non cede. first do no harm. Another study published this year looking at rates of error amongst pharmacists found that continuing high rates of presenteeism were associated with increased error rates. From a management perspective or a productivity perspective, there's also a huge economic cost of presenteeism. New Zealand Treasury conducted a study a few years ago now which attempted to put a dollar figure on it, and they found of the $4 billion or so lost in the form of productivity loss of ill health, presenteeism accounted for over 2/3 of that figure, whereas sickness absenteeism was actually only 3%. So proportionately, presenteeism costs a lot more in many ways. So the aim of this research was to examine rates of presenteeism across all of your DHBs. We just focused on DHB members. And we also wanted to probe what drives this behaviour. We had an excellent response rate. Over 53% of you clicked on and answered at least 2 questions, but the analysis in the whole was based on the 48% of you who answered all of the questions. Of the 1,800 or so, we had almost 40% left comments, and these comments are an incredibly important, rich source of contextual data. I do have a bias towards social data. I'm a social scientist by training, so I find examining these quotes incredibly interesting and illuminating. In terms of the demographic makeup, it was broadly representative of the ASMS membership, although we found slightly more women answered than men. And the statistics were analysed with non-parametric Spearman's rank correlation coefficients, and Kruskal-Wallis tests were appropriate. And we took a pretty standard p-value to indicate statistical significance, although we actually found that we probably could have used a p-value of 0.01. And in terms of the qualitative data, I treated it as a form of discourse and did a basic discourse analysis of it using an iterative process of thematic coding. So themes were allowed to emerge out of the comments, out of the statements that people left, and then I conducted a secondary quantification of the different themes to kind of give a sense of how proportionate these ideas were. So what did we find? This graph displays the findings to the Likert-scale questions, and you probably can't read at the bottom, it's a little small. The first one is, I have come to work when I have been too unwell to perform to my usual standards. The middle column is, I have come to work knowing I am unwell with an infectious illness, including vomiting or diarrhoea. And finally, my colleagues have come to work too unwell to perform to their usual standards. And this was over a 2-year period. The purple at the top is never, green is seldom, red is sometimes, and the blue is often. So if we turn this into basically a binaristic yes or no answer, we get quite a striking picture. We can see here, excuse me, that 88% of respondents had come into work unwell at least once over a 2-year period. 75% had come to work whilst they were infectious, and a really high proportion of you had recognised unwellness in your colleagues, 94%. Now these findings were similar to other studies. The Capital and Coast DHB study in 2014 used a similar methodology, a yes-no answer, and they found that 82% of their doctors had worked through illness. And also in a New Zealand context, Bracewell et al. Back in 2010 did a study down at a Dunedin Public Hospital, and they found that nearly 77% of doctors there had worked while unwell with an infectious illness, and this was in the context of a norovirus outbreak. So the patterns that we're finding are very consistent with trends in New Zealand, but also international trends too. The other measure that we had of presenteeism was a actual quantification of the number of days, and all this is based on self-reported rates, but and that is a methodological weakness, but in many ways, who else is going to know if you're sick if you don't know yourself? So it is a valid way of probing this issue. So this graph shows the grouped counts of number of days taken sick leave over a year and the number of days estimated to have worked through illness over a year. The median for sick leave days, which is the blue bar, was 1, and it was 2 days for working through illness, which is the red. And these, if we group these again, this is quite interesting. We find that over half of respondents had worked 1 day or fewer, and around about half had taken 3 or more days to work through illness. Now, in terms of the antecedents or the variables that we looked at any correlations with gender, age, according to decade categories. I know Seaton was interested in this. We kind of grouped it from 20 to 30, 30 to 40, 40 to 50, 50 to 60, and 60 above. Length of time worked at a New Zealand DHB, which DHB you were at, and the head count of doctors in your department. And we found that females were more likely to assert presenteeism according to the Likert-scale answers. And in terms of the quantification, we found that females or women doctors took more sick leave days, but also had more presenteeism days. And these are all strongly statistically significant associations. In terms of age, we had a negative correlation here, and we found that older respondents were less likely to assert presenteeism. And in terms of the quantification of days, we found the younger you were, the more likely, the more number of sick days you took, but also the more presenteeism days taken. And these are also strongly statistically significant associations. Time worked, of course, time worked at a New Zealand DHB isn't going to be an exact match with age, because you might have people who've trained overseas and then come here, so that's important to remember. But again, another negative association, we found that the more time worked, you were less likely to assert presenteeism, and the less time you'd worked in New Zealand, the more presenteeism days taken. We found no association between DHBs, so this should stymie any attempts to create a best and worst case DHB scenario. But interestingly, what we did find is that while there was no association with presenteeism rates according to the number of doctors in the department, we did find that the larger the departments, the more sick days taken. So I thought that was quite interesting. So why is this happening? Well, as you all know, if you're familiar with your MECA, it's not because you're going to use up all your sick leave entitlements. Senior doctors have a reasonably open-ended entitlement to take sick leave. What we found when we asked respondents to rank their top 3 reasons why they might work through illness was that they prioritised this duty to patients as the most important reason. And that's not surprising. You guys aren't working through illness because you're negligent. You're working through illness because you're really concerned that if you don't, your patients will miss out on access to timely care. The second most important reason that you gave was having clinics or theatre sessions booked. And this, again, ties into this notion of duty of care. And finally, the third most important reason given was not wanting to burden your colleagues. Again, you all have a strong sense of collegiality and that need to support one another, and this came out really strongly. Now, interestingly, in the TAN study at Capital and Coast DHB, that third reason, not wanting to burden colleagues, was cited as the most important. So a few differences there. Now, if we look at this in a graphical sense, the first 3 columns here is the duty to patient, having clinics booked and not wanting to burden colleagues. And the blue column at the bottom is the proportion of those who ranked this as the most important reason. So just keep that in mind when you look at the figures. Following that, we have fear of appearing weak, anticipation of workload upon return to work, not being sure of the threshold for staying away when ill, and not feeling unwell enough to stay home. So, it's reassuring to see that weakness and not being sure of the threshold were lower in proportion but there's also some interesting things suggested in those findings. In terms of the qualitative data, I found that presenteeism behaviour was described generally in terms of reasons why you people felt you couldn't take sick leave. So in that sense, it was quite important. You were describing presenteeism and sick leave behaviour as two sides of the same decision-making process. And that's a subtle but important distinction. Now, 66% of all comments referenced what I've described as structural workplace factors. And within this idea of not having cover was incredibly prevalent. People said there's just no slack in the system. I can't cancel my clinic because if I don't, there's no one else to do it for me. I know my workload is just going to build up, and I don't want to burden my colleagues. All of these themes are grouped under structural workplace factors. Now, also there was these really important cultural or professional behavioural norms that came through. 38% of all comments referenced these, and this included the idea that taking sick leave might be frowned upon as a form of weakness, and also a slightly different theme whereby doctors spoke of not feeling able to take sick leave for themselves because they had to prioritise their sick leave for their children or other dependents when they were unwell. And finally, we found around 30% of all comments referenced what I've termed thresholds of illness. And under this notion of, well, fatigue is also a really important reason that would affect my ability to perform efficiently at work, and this idea that fatigue needs to be given better recognition as a valid reason to stay home. And underneath this theme, we also had this idea of hidden illnesses, psychological illnesses, and a lot of comments said doctors need to give that a greater credence as a valid reason to stay away. So I want to share with you some more stories, because again, the comments perhaps tell the best tale. This comment says, the more senior you are, the more hard or difficult it is to replace you for leave, whether it's expected or unexpected. We don't have a casual pool available, and there is always the awareness of being a burden to colleagues and having to catch up on your return to work. So this sort of hits all those different ideas. Replaceability. Other studies have found that depending on how replaceable you feel, that's a really strong antecedent to presenteeism behaviour. But also this idea of there's just no cover. If I don't turn up to work, no one else is going to do my job. In terms of cultural norms, and this is where the title to the paper comes from, recently I tried to challenge our culture of working despite being sick, and I was told by my colleagues that if the SMOs stayed at home, there would be no one to look after the patients. Our unit has a strong SMO superhero culture, where SMOs are expected to work when sick and they're thought not to need sleep. So this idea of the SMO superhero is a really powerful signifier, I think. It's not so much that you guys think you're superheroes, although you certainly do perform miracles. It's more the fact that you're expected to be imbued with these superhero powers whereby you can carry on working despite onerous on-call, and you apparently don't get sick at the same rate as the rest of us. But at the end of the day, you're human beings. And finally, in terms of thresholds of illness, the other thing is how sick is sick, the commonest being non-specifically unwell. It's hard to know whether you should stay at home or not, and I've worked a whole weekend feeling suboptimal, but not terrible, only to discover that I actually had whooping cough. So this, of course, evidences not only the serious consequences that making the wrong decision can have, but also it sort of emphasises the need to have some kind of greater clarity around, well, when should I stay home? And perhaps some greater clarity around what the processes should be around that. So this is a nice lead into what can be done. Thankfully, there were some practical suggestions in the survey, and one of these was that perhaps job sizing activities need to have a greater proportion allocated to short-term sick leave cover. Now this, of course, is not my area of specialty, so if there are any questions, I'm sure Lloyd or other members of the industrial team can attend to that. And other suggestions were, as I've just said, that perhaps there needs to be these written guidelines or at least clear and explicit guidelines within departments stating the threshold to stay home when unwell. That might seem like a really silly idea, because of course you're all medical professionals, you know when you're sick. But what we did find was that a lot of people felt they needed some form of external validation or permission to stay home, and that perhaps these guidelines would be an important part of that. I think overwhelmingly this is part of a broader picture suggesting the entrenched shortages at New Zealand's DHBs, and it suggests that there does need to be more buffers and more attention to the senior medical workforce to enable the staffing up. And I think in terms of cultural things, we do need to basically reframe sick leave as legitimate, healthy and responsible behaviour, and I would suggest that management and those in leadership positions need to take and lead the way in that regard. So what are the concluding messages? I think what's clear from this study is that the low rates of sick leave that we found are obviously not a proxy for health. Presenteeism is commonplace, it's DHB-wide, and it's clearly an issue of concern. It suggests a workforce under an immense amount of pressure and stress, and I think the overwhelming idea is that you people should feel able to take sick leave when you are unwell, and if you don't, then there's something significantly wrong with the system. So, this does point to the need for greater investment in the senior medical workforce. I think it's an issue that the government can't afford to prioritise. And finally, this is a sneak preview of the cartoon that's coming out in the next Specialist. OMG, is this the zombie apocalypse? No, they're just 6 specialists working on the
tape around the top so I know which one's which.
Thanks very much.